Well, a lovely select little group this afternoon. Thank you very much indeed for coming. It's my pleasure to welcome Professor Margaret Studd to join us today, but also to her family who are at the back there. 3 generations are with us today, and it's a real pleasure to welcome them back. Those of you who know RHS will know that 6 years ago we started the Studd Society, a society that was there to help to promote and extend some of the thinking amongst our young people. And it was only fitting that when we were thinking about a name that we use one of our most preeminent alum in John Studd, and I had the pleasure of meeting John on a number of occasions. I know that the family has told me on a number of times how proud he was of his association with the school, and therefore I'm really delighted that this link with the family remains, and particularly to Margaret today, who will be joining us. I hope that many of you will be able to see something of her professional background. It really is quite impressive, and I can do it no justice. She's been at the Royal Free for many years, for much of her career, particular interest in HIV and the complications associated with respiratory illnesses. She's advised on a recent TV programme, and I know that above that she's continuing to practice daily at the Royal Free with interests in tuberculosis, HIV, and many other things which I'm sure she might touch on today. She's been a leading force as a female doctor and a female professor in research as well throughout her time, and continues to promote the importance of keeping HIV on the agenda. I'm going to stop there because I would like to use as much of the time to hear from Margaret. So Margaret, a very warm welcome to you this afternoon. Thank you very much indeed for joining us. I'm only sorry that more of our pupils can't be with us. Many of them I know are on the buses back from North Norfolk, but for now, welcome. Thank you very much indeed for being with us.
Okay, yes. So, good afternoon. So, actually, my working name, I never changed my name. Changed my name on my passport or whatever to start, but I've always continued to practice as Johnson because in medicine in my day, you had to, it was very much you needed to be recommended, so you had to change your job every 6 months. So if you changed your job and you were a woman, that was pretty fatal. So I have always remained in my maiden name. So sort of pressing the button on the computer, but so HIV Worldwide is really. So HIV Worldwide remains, at the moment we are, completely overtaken by the COVID pandemic, but actually, since the first cases of HIV were reported in the late 70s, it's a pandemic that rages on. And we think at this point in time, probably 38 million people worldwide are living with HIV. 7.1 million of those are unaware of their status. Now that's really, really important, as you will come to hear, in that if you are HIV positive, you don't know that you have HIV and you're not on treatment, then clearly you may pass this on to others. Of the diagnosed population, 15 million are on antiretroviral therapy, and their virus isn't adequately controlled. So again, that is, something that's really important in terms of driving the pandemic. And we think that in 2020, which is the last year that we have got data for at this point, I think that you'll see that reports from the years of the pandemic are delayed just simply because of the same people looking after HIV are also looking after COVID. So the last year that we have figures, we think 1.5 million new infections occurred. 690,000 people died with HIV-related illnesses in 2019. I think the good news is that certainly AIDS-related mortality has declined, and if we look at worldwide, probably UNAIDS estimate that that's declined by 42%. But we have a lot of concerns that progress towards lowering HIV incidence, i.e. lowering HIV new infections, is stalling. And in sub-Saharan Africa, if you look at the young people getting infected, 6 in 7 new infections in adolescence were among girls rather than in males. So how are we doing in the UK? So if we look at new diagnoses, as you'll see, that up until 2003, the number of new cases was rising year on year. And when we got to 2006 and we had effective antiretroviral therapy, which suppressed the viral load, and you'll all be getting quite used to viral loads and viral suppression, hearing about it every day around COVID, what we found is that the number of new diagnoses have dropped, and if you look at the bottom, you can see that the number of deaths from HIV-related illness has also remained stable. So if we go on to our next, and very low. So if we look at new HIV diagnosis in the UK, what percentage of patients have AIDS at diagnosis? Now, the people who die of HIV-related problems these days is people who present late, and they already have a very suppressed immune system, and therefore get opportunistic infections, which is what they die from. And as you can see, that if we look on the top, we can see really quite a very steep decline from 2014 onwards among men who have sex with men. But when we look at those heterosexual infections, we've been less good at reducing those numbers. And this is just looking at what happened to the estimated number of infections in gay and bisexual men between 2010 and 2019. And this is, sorry, I've not pressed the right button there. It's a different type of stick to what I usually use. That you can see the very dramatic decline. Now that isn't only about behaviour change. I think the one thing that has really been a game changer is that we have identified that if patients are on pre-exposure prophylaxis, so the antiviral drugs that we use to treat HIV infection, if they are used in people who perceive themselves to be at risk of being infected, they can prevent the individual being infected. So that is called PrEP, and we are able to use 2 drug regimens rather than 3 drug regimens in those populations. And we're now moving from tablets to injectables. Those injectables can be delivered 2 monthly, and the number of new injectables becoming available is increasing all the time. So if we just look at the estimated number of people with HIV living in the UK, as I said, there's about just under 100,000 individuals. Actually, we think probably the number's gone down a little bit during the pandemic because many people have gone home. So, in fact, it's probably just under 100,000 people living with HIV in the UK at the moment. And we look at the proportion of patients that are diagnosed. As you can see, we're doing pretty well in the UK in that the majority of patients, really across all our patient populations, are diagnosed, but perhaps we're doing best among gay and bisexual men. And if we look at the numbers for London, it really is very much the same, but in London, we continue to do better among gay men, but perhaps less well outside of London. Now, I think the most important thing is how the antiretroviral therapy has been a complete game changer in terms of life expectancy for patients with HIV. So if you look at people who were diagnosed at in between the years 95 and 96, a 25-year-old with HIV had a life expectancy of 34.5 years, diagnosed 15 years later, 15 to 20 years later, that life expectancy was 73.9, getting towards normal. And there are some studies from, this is UNAIDS data, but there's data from the UK that actually sometimes life expectancy for people with HIV is actually better than the normal population. And that's because they have regular medical care, they're regularly monitored, and clinical teams are doing good. So on to why those improvements have been made, and as I said, it's around antiretroviral therapy. Now I'm going to come on to talk about everybody with treatment and with HIV as soon as they're diagnosed are advised to start on treatment. Now that wasn't always the case. I think that at the beginning of the epidemic, very much there was worries about the toxicity of the initial antiretroviral drugs that we had, so we very often would advise patients to wait till later to start treatment until their immune system was low. But actually, it's very clear now, and it's very clear for the patient itself, but also for the population, that starting on antiretroviral therapy as soon as you're diagnosed is important. And what some of the powers of antiretroviral therapy is clearly saving lives. It prevents mother-to-child transmission of HIV, and I haven't had an infected baby in the practice at the Royal Free for over 25 years. It can be used as post-exposure prophylaxis. So if a member of the clinical team has a needle stick injury, again, post-exposure prophylaxis, taking antiretroviral drugs will prevent, it doesn't totally completely prevent, but does reduce the risk of that individual being infected. Now again, if the person with HIV is on treatment and is undetectable, the risk from that needle stick injury is very, very small indeed. So restoring respect and dignity for people living with HIV, they no longer need to be concerned that they, as soon as they meet a new partner, that they have to disclose their status. If they're on treatment and they're undetectable, they're not going to infect their partner. So that really has been a very big game changer in terms of quality of life for many of our patients. I talked to you about pre-exposure prophylaxis for people who are at higher risk. We know that also that the person who is on antiretroviral therapy in those areas of the world where this epidemic rages, it prevents tuberculosis and TB-related deaths, and TB transmission is reduced. And that's because their immune system is stronger, so that they don't get infected, and if they do, that they clear it and survive. So it means that many of the patients, I remember in the early days of HIV, my outpatient clinic would be full of people in wheelchairs. They were often having drugs via drips, which they were self-administering at home. And now it's full of people with mobile phones, late for work, telling us to get a move on. So it's really been a game changer in terms of getting back to normal life for patients. It clearly has also been very important, and this remains really important in sub-Saharan Africa, where so much of the HIV epidemic is present, in that it reduces the number of children becoming orphans. And so preventing HIV transmission among serodiscordant couples, and also reducing maternal mortality, clearly very important for their children. So UNAIDS has come up with a aspiration that what we should be aiming for is treatment for everybody, that 90% of people with HIV should be diagnosed, 90% of those patients should be on treatment, and 90% of patients should be on antiretroviral therapy with a undetectable viral load. And if we look at the situation worldwide, probably only 59% of people living with HIV are known about and are on antiretroviral therapy and have an undetectable viral load. So what about how are we doing in the UK? So just remembering, we're going to be aiming for 90% across the board, and we're doing pretty well in terms of people living with HIV. We think that 94% of people in the UK with HIV are diagnosed, and of those, 92% are on treatment, and of those, 89% are virally suppressed. So we are getting there, but as you can see that when you look at that along the continuum of care, sorry, I should have gone. The continuum of care, that actually we still are not quite there. And in the UK, that London has become a fast-track city, has had a lot of investment in order to try to achieve that 90-90-90, but to increase the number that are virally suppressed. Now, as I said as well, that it's very important that patients are diagnosed early. So we would say that the aim has to be that people with HIV should be diagnosed when their CT4 count is above 350. And as you can see, so if you can see, we still are failing on that number. And the issue is, if you're diagnosed late, the issue is that you are at increased risk of opportunistic infections. And the people who die of HIV in the UK who present late with an opportunistic infection still have substantial mortality. When we look at who is diagnosed late in terms of once they are diagnosed and started on antiretroviral therapy, how are we doing in terms of reaching that target where patients are on antiretrovirals and have an undetectable viral load? And what you'll see is we're actually doing really well, apart from in younger age groups. So in the 15 to 24 age group, that is often the case for many medical problems, that it's in those sort of teenage, younger years that it's really more difficult to engage them in medical care. So antiretroviral therapy, in the 1980s, patients would be taking handfuls of drugs, they would be taking different combinations, they would often be on schedules where they were taking 4-hourly intakes, they would be waking during the night with an alarm clock to take their tablets, and antiretroviral therapy has moved forward enormously since then. So most patients now are on one pill once a day. There are also injectables, which have recently, the first injectable has been licensed in the UK, has been approved by the NHS to be used in patients from the beginning of April. Now, for many patients, that also can be a game changer in that the injection, this is the first in class, and the injection is every 8 weeks. So it really makes a real difference to patients who really hate taking their pills, the reminder that they've got something wrong with them, and also from the point of view of those patients who have problems with adherence. So what are the benefits of antiretroviral therapy? Well, firstly, it's really important to the individual. If they're on antiretroviral therapy, as I've said to you, that greatly increases their life expectancy, and they should be able to achieve a normal life expectancy. And as I'll come on to discuss with you, HIV and the antiretroviral therapies may be associated with other long-term health issues, and those are reduced in patients on treatment. Clearly, the benefits of antiviral therapy to the population is first and foremost reducing transmission and new infections, but also has a substantial benefit in terms of healthcare costs. So what is very clear, as I've tried to emphasize, is that undetectable equals untransmissible. And now there is very, very good evidence from a number of clinical trials in all different demographic populations that if you are undetectable, then you're not going to transmit HIV to your partner. And this is a statement from the Centre for Disease Control and Prevention, and this was back in September 2017, that people who take antiretroviral therapy as prescribed daily and achieve and maintain an undetectable viral load have effectively no risk of sexually transmitting the virus to an HIV negative partner. And I think for patients that message and that data really changed their lives. So I hinted at that HIV is associated with an increased risk of other comorbidities, and the particular ones that I want to raise are there is a raised rates of hypertension, increased cardiovascular risk, leading to myocardial infarction, peripheral vascular disease, and impaired renal function. And if we look here at the main number of comorbidities in an age-matched population, HIV across all age groups is 1.3 comorbidities, in the HIV negative matched population at 1. So there is an increased risk of multiple comorbidities in our patients. And what are those comorbidities? As I've said, they include blood pressure, obesity. There's a problem with many of our antiretroviral drugs about concerns about putting on weight. Patients with HIV have smoked more than the comparative population of HIV negatives. There's an increased risk of diabetes. Again, that's mainly associated with medication. There's an increased risk of hyperlipidemia. There's increased alcohol intake in the patient population, and also issues around mental health. And I think that for many of those areas, that there are some things you can't change. You can't change age, ethnicity, or family history in terms of comorbidities, but you can reduce smoking, reduce alcohol, try to increase exercise, maintain normal weight, identify, treat hypertension, identify, treat dyslipidemia, so high cholesterols, and try to encourage our patients to reduce substance misuse and also social isolation. So, as I said, I think that with us seeing this really very remarkable improvement in terms of life expectancy, I think that many of those things we're going to see really change in our patient population. And I certainly know that although HIV in our cohort shows that our patients are more likely to smoke, that is declining year on year. Similarly, drug misuse, alcohol misuse, again, is declining. I think weight continues to be a problem. As I said, that weight increase is seen with some of our best antiretroviral drugs, and again, that is with newer treatments coming along, hopefully that will improve. So just where are we now? I think that in conclusion, from an achievement point of view, we've improved life expectancy dramatically for people living with HIV. I think that the data that shows that if you're undetectable, you're uninfectious, has really empowered our patient population and has made a huge difference to their lives. As I said, new drugs are coming on with with less drug toxicity. We've now got a new way of administering drugs. Injectables are now licensed in the UK, so this is a 2-drug regimen. This is going to be available on the NHS. I don't think that this is going to be suitable for the majority of patients, but for a small number of patients, this is going to be really important. And the reason why I say that is that it is the first in class. They're rather big injections. You have to give them intramuscularly rather than into the subcutaneous fat. And there is a slight increase in antiretroviral failure resulting in resistance. So I think for most patients it still will be taking their 1 pill once a day, but there are many different injectables on the horizon, and they're going to clearly be important for patients going forward. And I think that the other real achievement is finding that antiretrovirals can be used to prevent HIV in people in the at-risk population of those becoming infected. So what are the future priorities? Well, I think obviously everyone working in HIV and all our patients want a cure. I mean, that's the most important thing. I mean, probably every time I do a clinic, people will say, what's new on the cure horizon? I think that prevention needs to play a central role in HIV research, and I think it is now beginning to do that. And as I said, the importance of patients, those people at risk for HIV, having access to PrEP. And I think that we need to wait and see what effect COVID has had on the delivery of HIV care. So with clinics being for long periods during lockdown, being closed to patients coming in, and whether that's going to have an impact on HIV outcomes, and whether our services will go back to what they were previously, which was very much about providing holistic care for our patients. And as I said, that the knowledge that they do have an increased risk of many comorbidities, actually being properly monitored for that is, I think, that what we all need in terms of our healthcare. And HIV, actually, clinics were providing that, but I think that we're very keen to get back to business as usual. I think this is a really important statement from Anthony Fauci. You probably won't know about him for his HIV work. You probably know about him for his work on COVID and his standing up to Trump. But he said in 2021 around HIV, so why does this global pandemic continue to rage? It's not that we lack the medical advances and interventions to end the pandemic. It is that our proven tools have not been implemented adequately or uniformly. And again, this is very much around where most of this epidemic, new cases are occurring, which is in sub-Saharan Africa. In the same way they haven't got vaccines, they've also not had the same access to antiretroviral therapy. Just a couple of things to say. This is looking at my patient population, and I think that there is an increased prevalence of mental health conditions in the patient population. As you can see, 38% of the people reported depression, 30% anxiety, 21% insomnia. And when you compare that with the general population, as you can see, they remain with higher levels. In terms of disclosure and discrimination, we asked our patients, sorry, I haven't put the slide on, sorry. So we asked our patients in the past year, because of your HIV, have you worried about being discriminated against in a healthcare setting? And 13% said they had. 17% said they avoided seeking healthcare when they needed it, and 6% actually being refused or delayed a treatment or medical procedure. So we're not there yet. There is certainly still discrimination and disclosure outside of healthcare. 9% of our patients had told nobody of their diagnosis, 69% had told some friends, 62% only had told family, 68% had told their sexual partner, and 26% had told other people. So, still disclosure remains a major issue for many of the patients we look after. And I just thought I would just end with a slide about HIV in the UK, in the Ukraine. 250,000 people are estimated to have HIV in the Ukraine, and in terms of Eastern Europe, that's the country with the highest prevalence of HIV. 1% of the total adult population is infected. There's a very high risk of drug misuse and injecting drug misuse in that population. And when we think about that target of 90% diagnosed, it's estimated in the Ukraine that only 67% of people with HIV have been diagnosed. When it comes to them being on treatment, again, the target is 90%, but only 80% of those who know about their infection are on treatment. And then when we look at whether they're on treatment and that treatment is working and they have an undetectable viral load, that is 95%, which is well below the 98% we see in the UK. And overall, this equates to 54% on treatment and 51% of patients being virally suppressed. I think the other big issue for the HIV population in Ukraine at the moment is there is a huge shortage of drugs already. Many patients don't have access to drugs. So many patients who've changed their regimen have had drugs at home and still have open boxes. They can't ever were never allowed to recycle drugs via the pharmacy, but many patients have been bringing drugs in, and within my clinic, they're being collected and sent to the Ukraine, and hopefully they get to the right patients. So with that, I just say thank you, and I think that's all I've got to say, so happy to take questions. Sorry, I wasn't very good at the pen. It's not one I usually have a clicker, so it's... Yeah.
Has your experience influenced those managing COVID?
Has my experience managing COVID? It's quite interesting. So my chief executive asked me to talk about that to the hospital. I think it's very different. The issue with COVID, it affects everybody. So it's not stigmatized to the same extent as HIV. And that, again, I mean, from my point of view, HIV is a viral infection. It's transmissible from person to person. Why is it any different to, COVID? But I think there is, just, the amount of press coverage, clearly also it all happened very dramatically while HIV has just smoldered away and the numbers, increased. But I think people are much more open to talk about it because it affects everybody and everybody's worried and thinking about it. But I think the big message I would say to you is so many of the medical problems we have are transmitted, via coughing, via, fecal oral route. Why is HIV any different? Unfortunately, we do infect each other with, many, many different viruses and bacteria, and this shouldn't be seen as anything different. Yeah. Yes, it is. Yeah. Yep.
What inspired you to study HIV as opposed to other diseases?
Why don't others? So I am a chest physician by training, and patients with HIV, we didn't talk about what infections what medical issues they got when they are very immunosuppressed. So actually, most of the patients, the most common problems are respiratory. And so pneumocystis carinii pneumonia, which is a fungal pneumonia, and tuberculosis are very common. There was a skin problem caused by a herpes virus, HHV8, called Kaposi's sarcoma, and that caused problems in the lung. So there were many, many different lung complications. And in the Royal Free has the biggest haemophilia clinic in Europe, and all the severe haemophiliacs were infected by blood products. And they have been a very important cohort of patients because they were involved in hepatitis B vaccine trials in the mid-70s, and they collected blood every 6 months. And so you were able to pinpoint exactly when they became infected. And that population, a lot of them died very early in the early 80s, prior to my time. But there was a sort of a cohort that remained, and they had an issue about going to sexual health clinics, which was where most of HIV care was provided. And when I started, sexual health clinics tended to be in the car park, hidden away, and I think there was a view within the hospital that they, wanted this to be very much seen as a medical issue in the heart of the hospital. So as I was the respiratory physician, I became patients were channeled towards me. And that's a really fantastic group of patients, in that I think there were probably 40 who survived when I started. Most of those are still alive today. Yep.
Is there a risk with the antivirals that the virus will mutate?
Yes.
Yeah.
So if you're not adhering to your medicines, so most patients are on either a 2 or 3 drug regimen. So if you miss doses, the issue is the drugs will have different half-lives. So you end up being on a single drug. And we know with monotherapy, and it's going to be the same with COVID, with monotherapy you get resistance. So initially, successful antiretroviral therapy was with 3 drug regimens. There are now some 2 drug regimens that you can use. But if you miss pills or you stop and start, you'll get resistance. And that's one of the big challenges for most of the world. I mean, for Ukraine, a major issue. If they don't get drugs, they'll have the 3 drugs with different half-lives, and that there'll be a whole population who've been adherent to their therapy who may get resistance. Yep.
What's the treatment programs like in Africa and the developing countries?
So I think the interesting thing is that there's always been a sort of a view that the issue is that people very often in countries with not well-developed medical systems, that they are going to be chaotic about taking their treatment and whatever. I think the issue is actually in Africa, they have very high levels of success once they're diagnosed and once they're on treatment. I think the big issue is getting to a place where you get diagnosed. Many can't afford the bus fare, or it's however many miles to walk. Certainly the US with their PEPFAR and the Gates Foundation have been enormously helpful in terms of getting antiretroviral drugs to many populations, but obviously, as you can see, not to all. So I think that the key is that actually the outcomes in those, if you look at clinical trials, there were much better outcomes from patients in Uganda rather than patients in the US. The problem with the US is they have actually some of the lowest outcomes for successful treatment, i.e. undetectable viral load, and that's because their healthcare system means that, yes, if you're the very poorest and if you're well off, you're fine, but the people in the middle who can't afford it. Yeah.
For you, what's been like the most crucial moments or turning points in your personal career?
What's the most that's a really difficult one. I mean, I've sort of had lots actually. So, I mean, look, I've had a really fantastic career. I mean, I remember actually applying for my job, and someone who I absolutely, felt was, someone totally to, follow in her footsteps. She became the president of the College of Physicians, and she said to me, "Oh, don't apply for that job." And I think it's the best thing that she said, because there's no doctors, you've got no junior doctors, you don't have any beds, and actually to have to build something that met the needs of the patient actually was fantastic. And I think lastly, I've been very involved in trying to get access to COVID vaccinations. So I've been very involved in North Thames in delivering the vaccine trials. So I think that's another high point. Yeah.
Given the success of the antiretroviral drugs and the extended life expectancy, what's the likelihood of HIV no longer being a disease of concern?
So as you can see, we're not doing well enough. I mean, the reality is that nobody should die of HIV these days. They should be diagnosed in a timely manner. They should be on the right treatment. They should be properly monitored. But it's all down to resources. So I don't think until we have a cure, we're going to get anywhere near that at the moment.
Just following on from Lucy's question about Africa, we're involved in a charity in Uganda, and during COVID they didn't go to school for 2 years, and we are aware that there was a significant rise in teenage pregnancies in Uganda at that time. Do you think that COVID will have increased the amount of HIV cases in Africa because they weren't going to school?
Yeah, and they weren't being educated. They didn't know probably that they didn't have the same access to information as to how HIV is transmitted. Again, I don't know, but what happened to HIV services during that time. And as you can see, I mean, usually every year we will get a UNAIDS update, we'll get a UK update. All of this is still 2019. So it's all stalled because of the same people are looking after HIV are looking after COVID. Sorry, did you want to ask something back?
Yeah, so how do correlated disease susceptibility rates for HIV patients compare to those with, say, SCID or who are medically immunosuppressed?
Sorry, say that again, I didn't quite hear.
How do sort of correlated disease rates for HIV patients compare to those who have SCID or might be medically immunosuppressed? How do they compare?
So I think there's not terribly good data around that. I mean, I think that, clearly immunosuppression, these days is, for a large variety of reasons. It can be just aging, it can be you're on chemotherapy, it can be you've had a transplant, it can be you have an HIV. And all of those populations do have an increased incidence of TB. Is one much worse than the other? I think the issue is now with HIV, if you're diagnosed early and you get onto antiretroviral therapy, your immune system pretty much goes back to normal. So actually, if you've had a transplant, you'll never go back to normal. You'll always be taking those immunosuppressant drugs. So I think, HIV hopefully will be doing well. And the number of the amount of TB in the UK is falling as well.
Well, thank you very much. Ladies and gentlemen, thank you very much.
I'm really sorry about my slides, that I didn't keep pressing the buttons right.